There's going to be a downward pressure on appointments in a private or mixed billing setting. So downward pressure on appointments, which means empty appointment slots, possible and likely, especially because many corporates are flooding their practices with bodies. Sorry, second of all, so that's in a private or mixed billing setting. In the bulk billing side, there is a potential pressure of increase on appointment demand.
Hey, welcome to Sachin from Scale My Clinic. Now, this episode is a little bit different. It's an excerpt from a private workshop we ran recently for general practice owners, and the response was huge. During the session, we talked through the November bulk billing reforms, what they really mean for your practice, things you need to watch out for, how to protect yourself and remain profitable whilst everyone's scrambling to adjust. You're going to hear a section of the workshop where we unpack some of the traps and some of the dangers, whichever path you choose, so that you can overcome or circumvent those traps. The risk is, if you are not aware of these traps or some of the whammies that are coming, it could quietly wipe out your margins. And so this session was raw, it was practical, and it was taken straight from a live room of owners working out their response plans. So if you're feeling uncertain about what the reforms might mean for your model, for your team, or for your future, or if you just want to sense check that the preparation you've done is correct, then listen closely. You're going to walk away with some real clarity on what to protect, what to change, and how smart practices are preparing right now. So here's a look inside and all the traps that practice owners need to avoid, regardless of which path you've chosen, whether it's remaining some form of private billing or you've gone down the UBB path. Enjoy.
Has anyone seen the Health of the Nation report that came out 2 days ago? The college releases it every year. Really interesting insights. And so maybe we might start with something interesting that is relevant to all of us here from there. So let's do that. Let's start here. This is the Australian government spending on general practice services per person over the last few years. And what you can see is, this is billions down here. In 2019 to 2020, it was 11.886 billion. Okay. And last year it was 12.199 billion. If it had gone up even with inflation, it would have been 14.2 billion. And look at the hospital funding per person, steadily crept up. All right. And so does that surprise anyone that real term funding has gone down? Yeah. So I think despite all the rhetoric, we're barely even with the new money going in. We'll be lucky to even catch up to where it should have been, just based on where it was 5-6 years ago. And so that's just a clear systematic underfunding of general practice. And who carries the weight of that? Tell me, who carries the weight of that? Yeah, GPs, owners, etc. Okay. The other interesting figure, and remember this is only 2 days old. This information was just made public two days ago. The interest in owning a practice, okay, the no's have now crept up to 82%, 80 of GPs who responded to this survey. And the yeses slightly crept up as well. The fence sitters went down. Is it good for general practice if there's less GPs wanting to own? I don't think so. And then interestingly, there was this question around viability. Last year hit a peak where 81% of owners were concerned about viability. It's still well over a quarter. I'm always intrigued about the don't knows or unsure if they're worried or not. Those people are probably watching Netflix. We've got nothing else to worry about. But what it's telling us is that pretty much 4 out of 5 owners are worrying whether they can keep up. And that might be you. Maybe you've experienced sustainability issues, costs rising, rebates not keeping up pace. And so who here has concerns about viability? Just share with me who has had concerns about viability. And what are your specific concerns when it comes to viability? That would be interesting to hear that and share. What specifically about viability? Is it on the income side? Is it on the cost side? Is it on funding? right? Just paying the bills and wages. Yeah, staff costs. Yeah, costs are ever expanding. Yeah, and if you read that survey, I've just done a surface level read, not full. Costs and rising costs was top of the list actually, which was interesting. All right, so let's get started. I just want to remind you, we'll cover some stuff, but we're focused very much on the November 1st changes today. And I just want to go over where we're at right now so that we can build your response plan. Okay. And so when we talk about this, my assumption is that we're all aware of all the changes. And so I'm just going to do a quick whistle stop over the changes that are coming in so that we can really get to how we're going to respond, because I think that's more valuable. The knowledge and the information about what's changing is very publicly available. So we'll just do a quick overview and then we'll get cracking on to doing some work. So first of all, 2712 and 2713 will be going on the 1st of November. We're all aware of that. Yeah. What do we think of that? What do we think of that? From the data I've seen, that definitely discriminates against female patients and female doctors, and discriminates against slow medicine, which has proven to be better for outcomes from what I've seen. Yeah, Naveen, what is coming instead of them? We'll cover that today. But I can give you a hint. Rhymes with "uthing." So that was my hint. I think you can work it out. All right. You have to laugh. You have to approach this with some humor, and we'll do some serious work on it as well. Okay. 721, 723, 732 also went. Okay. And so it was replaced by 965, 967. And when it went, what that meant is if you took or if patients had that service regularly, then over the course of a year, the equivalent funding decrease was 20% in item numbers. Who's feeling the pain of that? Who's felt some pain from that? Cool. But now what happens? Everyone gets the bulk billing incentive. All right. In certain cases. And then even more of them, if they sign up for MyMedicare, get some other bulk billing incentives. We've had CCM come, and the criteria are such that potentially you can offer that to a larger group of patients with the way the definitions are. And then for those that choose the path of universal bulk billing and fulfill the requirements, there will be the addition of the bulk billing PIP, which is a 12.5% supplement on certain billed items, split evenly between GP and practice. And the government's very accurate, specific calculator tells us that when you put your numbers in there, it will tell you what it will tell you. And those numbers were obviously put together by someone who has done a lot of general practice in a variety of settings, and really knows the business, and is not a management consultant sitting in an ivory tower somewhere using probably ChatGPT. But that's a whole other question. All right. And then our friend in Canberra is telling everyone, holding the Medicare card up proudly, that 90% of GP visits are going to be bulk billed by 2030. This is something that they've committed to, and there's a strong possibility of at least a two-term government, and therefore we need to be aware of that agenda. Okay. A moment ago, I showed you this number, and I showed you how over 3/4 of owners are wondering about viability of their practice. Many of you shared the same. Interestingly, at the room in our last event, I asked the same question, and only 20% of owners there, some of you may have been there, only 20% were concerned about viability from that room. And so I'm thinking you're here because you want to know what those owners may be thinking, what they know and what they do differently, and that you probably want to apply that to what's currently going on with November's changes. So that's the assumption I've made. And this is why you should listen to us. Scale My Clinic, we're here for one reason: to help private general practice owners build thriving, profitable practices, sustainable practices, without feeling like they're constantly drowning in work. We've helped hundreds of practice owners transform their practices by working with us in Project X, which is our proven coaching program. And that helps owners reclaim time, build a high-performing team, and boost profitability. We're a CPD partner with the college, and we've done a fair amount of work on advocacy because we believe independent practice is the backbone of quality healthcare in Australia. we are not here for corporates. Okay. And so if you're from a corporate, we're not for you. We only work with private owners because we know and have lived, overcome, and helped others overcome the same challenges faced by you. I'm going to show you some of the things that have been working and the way people have been approaching these challenges successfully. I'm going to show you some key shifts and talk you through some key shifts that will make the biggest impact so that you can see where you need to focus on. And I'll give you everything I can in that time. Some of you will take it and run with it. Others, you'll want some help applying it faster. So I just want to take your permission if at the end of our time, you're okay if I give you the opportunity to take this further if you decide you want some help making it happen. Okay. All right. Let's keep moving. So when we talk about building a great practice, we're really talking about climbing a bit of a pyramid. At the bottom sits what we call the nightmare job. This is where you're doing everything, rosters, chasing up the BAS, filling in gaps in the clinical side, doing payroll at odd times in the night. You're really working twice as hard for about half as much as you might get working for someone. And you're doing it just because you don't have to work for someone else. The team at that point is mainly friends, family, and what Todd calls freaks. They're the brave souls who said yes when no one else would. You love them for it, but this is a time where you feel stuck with time, profitability, marginal. The energy can really start to drain, and it can make you feel exhausted. But with enough grit, you can cross that line of fear and ignorance. You realize you don't have to do it all yourself, and you realize that maybe you're the bottleneck. And with enough grit, you claw your way up to the next layer, the well-paid job. Here, you're often earning well. With time, you can take the occasional long weekend, but it's still you. If you don't show up, things don't move. Some months there may be profit. Some months it may be the cash crunch where it feels a bit panicky. And you can often still feel a bit of a bottleneck there. From there, the next layer, when you're less opportunistic and you're more selective, is what we call the real business. And this is where systems start to work, the PM and the team start to step up. You can finally take a proper holiday, although often it'll only be when no one else is away. And you're starting to be profitable here. Typically 8, maybe up to 11% of billings, but you still don't feel free. But you can look around and see people not doing as well as you, and so you can get comfortable here because it feels good enough compared to what you see. Once you sort of transit past that line, that okay is good enough, and you realize that maybe you're trapped by complacency, that's when you can reach the top layer, the asset layer. And this is where the practice can work without you. It's humming, the right people are in the right seats, decisions are happening without you. And this is where margins start to get to 15, maybe up to 20% of billings. You've got more time freedom here and some financial freedom. And to give you a story and an illustration of this, an example might be someone we worked with who, when they started working with us, we worked for about 2.5 years together. They had 2 sites. Profit was around 550,000. And so the valuation of the practice was somewhere around 2.5 million. Pretty good, right? A pretty good business. For 2 years, they worked on implementing better systems, driving revenue, restructuring their leadership throughout their organization. And over 2 years, the profit went from 550 to 1.6. And the valuation, because of the change in the way the practice was run, instead of a 4 something multiple, went to a 6 multiple. And so that person exited for 9.6 million. And the best part is they didn't have to expand to sites. They didn't have to grow. They just did the work that took it from a real business up to an asset. And so my question for you is, right now, which layer are you in out of these 4? Which layer are you in? Awesome. And where do you want to be? And what difference would it make to you to be there? What difference would it make to you? Okay. This is the link on YouTube. If you're not subscribed to it, I seriously would get subscribed to it. People tell me they speed me up to 2 times. It's worth listening to. We have some really good insights on there and some really good interviews with other people on the ownership and leadership journey. There are plenty of nuggets to share. And so take a screenshot, sorry, a QR code scan of that, and then just subscribe to that. You'll find it useful. Okay, and this is what I know, and use what's useful from it for you. It's very hard to unteach and unlearn free. Okay, so if you haven't chosen yet, this is particular speaks to you, but it may also be relevant whichever path you've chosen. Okay, when I arrived in Australia in 2008, I came as a GP, and even as a GP in the UK, I would never have thought to put my hand in my pocket to go and pay for any type of health or allied health service. I would have waited for months. So I would have, if I needed a physio, I would have gone to the GP, I would have waited, because it just is not taught to you at all to even think of contributing in addition to your tax contributions. And so that sounds great, you know, everything provided by the state, universally accessible, etc. The reality now, speaking to many close friends I have in the NHS, is that the NHS still does provide universal healthcare, but it is universally crap for everyone, particularly general practice. And so I don't know about you, but as a GP, for me, I just want to give my patients the same level of care and attention that I would want for my family. Like that was my basic sort of approach when I was seeing patients. That is very, very difficult to do now in that system at all. And weirdly there, even those who now do want to pay and contribute that can't, because the system is not structured to facilitate that. Whereas here, of course, we'll remember people who don't want to spend a penny on their health, but generally people are used to contributing something. And so it's an important lever to keep, because that does protect autonomy and keeps us a bit different to the UK. And so last week I had some issues and I had to go to my GP, and I saw the GP. I had blood straight after. I needed a CT scan, and I think I started the process on a Monday afternoon, and by Thursday I had all my answers. And so what that means is I had speed of access to the doctor, I had speed of access to investigations, and speed of access to a diagnosis. And that's why, one of the reasons why we have better outcomes here than the NHS. There's still an inequality. It's no means perfect, but I can tell you without a shadow of a doubt, it's better than what goes on there. And so I think from our perspective, my results were all good, so it's all good. But that cost me $57 out of pocket. And so I looked up, I did an AI search. What would that cost me in America, in Canada, in the UK, and how much time would it take to get that access? And I have family in all of those places as well, so you know I have these conversations with them. In the UK, pretty much not possible unless you're paying sort of 1.5 to 2.5 thousand Aussie dollars for that. US, let's not even talk about the US. Canada, you're talking an 8-week wait at least for the CT. Pretty crazy. And so one of the reasons we exist here is because we, and I think all of us here, deeply believe in the power of strong primary care. And we, Scale My Clinic, think it's best led by private business. And so we want to do everything in our power to strengthen and support it. And so whichever pathway you've chosen, okay, today we want to help you make the very most of it by building on what's great about general practice, okay? And so I think it's just really important that we make sure that we're clear on that, all of us, because what we have is actually very special, and we would be foolish to give it away lightly and take a path that is proven to be worse. Proven. Okay. And so even if you've chosen the bulk billing path, it doesn't mean I'm suggesting you change. It's not about that. I just want you just to be careful and wary of wherever free shows up. And if you're in the unsure category, just be careful of the word free because of the training and untraining that you have to do of patients. All right, so I just want you to keep that in your mind as we talk through the rest of today. Are we good with that? All right, so let's go. What we're going to do now is we're going to go to a breakout, okay? And what I want you to do is you're going to share your model there in the breakout, okay? And then I want you to think about, what are your biggest concerns when it comes to the pathway you've chosen? What are your biggest concerns? What do you most need to address? Okay, you clear on that? So you're going to share in that breakout, you're going to share, this is the billing model I'm choosing. And if you're unsure, you say, I'm not sure yet, I'm still working it out. And then you're going to say, this is what I'm worried about most with the pathway I'm going to choose. All right. And often I get a message or two in the middle of a session. And so if that's you, you're super ambitious, you want to grow faster, then use this link, book a time with me. I will personally do a quick audit of what's possible for your practice. It's only me, it's not some random. I'll spend 20 minutes with you. I've done it a few hundred times. I can pretty quickly see what's possible for you. So if you're one of those super ambitious people and you're like, look, I just want to take the shortcut, please help me, then let's spend 20 minutes together and we can do that. Okay, so you can use the link or you can take this and off we go. All right, now normally we would talk through our approach to solving the problem of success in general practice, but today we're not going to do that. What I'm going to say is that the center of everything we do is what we call success in heart, mind, and wallet. That's doing good work, helping patients, building a practice that rewards you financially. And so for that, there's three things you would need. Okay, automatic income. That's income that's generated by others, not reliant on you seeing every patient. Complete choice, freedom to decide when, how, and if you work. And then a dream team which is a high-performing group of clinicians and non-clinicians to help you deliver care and grow the business. All right. And then there's three levers we talk about there that are super important: strategy, leadership, and recruiting. And then there's 9 accelerators, which I won't go through, around the outside. Today, we're only going to be focusing on a narrow part of that because I don't want to overwhelm you, and I want us to really focus down on the key points that you need to be thinking about right now. But it is important to say that the people we work with in Project X work on these for months and years. And to have sustainable success over the long term, you need to consistently work on all 9 of these areas on the outside. Okay. And people typically working with us do that for an average of 36 months. And so I can't go through every nuanced part of that in 120 minutes. So we're going to focus on just the key things to help you go forward. Okay. I just want to make that clear, because it is very important that I don't misrepresent that. Okay, so first of all, I think one key thing that I want you to just bear in mind is that the baseline is going to move. All right, so you've got to be prepared. It's the motto of the guides and the scouts. And the way the baseline is going to move, if you're not prepared in November, is that paying patients are going to choose their preferred practices. Number one. And then many of the best free patients, the ones who are bulk billed, will also choose their homes. And so then you're going to be left with more of the transient, non-longitudinal, unattached group who then use a service. And so that's one risk you have to be aware of if you're not preparing and not deciding soon which way you're going to go. Whichever way you go is cool, but whichever way you go, you've got to go 110%, right? Don't be caught sitting on the fence, because the best opportunities on both sides will get sucked up, and then you'll be left more reacting to what's left. So that's just one thing I think is really important. Okay. So today, out of all those accelerators I talked about, we're really focused on 2. And those 2 are going to be here. There's risk management, and then there's income sources. And they're the 2 that we're focused on. Okay. And there are 3 principles that I want us to be thinking about. And so those 3 are as follows. Okay. And we're just going to, and these make up the 3 parts of the plan that you're going to work through today. First of all, we've got to mitigate the risks, whichever pathway you're taking, and I'll talk you through the main risks that we need to be thinking about. Okay. Then you need to decide on some trade-offs. And so again, we'll be working on that. And then finally, which is probably the most controversial, is you've got to design your days. And so we'll talk about that. Okay, clear enough so far? those three things, that's what we're going to work on. Okay. So what I'd like you to do is, first of all, I'm going to give you 90 seconds. There are a variety of risks that are coming with these changes. We may have touched on a couple so far today. I want you to think about what are those risks for your practice. And I just want you to list them out. Okay. So with the November changes, what are the big potential risks for your practice? And then we'll keep moving. I will, of course, be sharing some with you. Don't worry. But I want you to do some work first. All right. So 90 seconds. Off you go. Write them out on a piece of paper for yourself first. Then if you want to type them all out, don't share them yet. Just do your list for you, because it will be a bit different in each setting. And then looking at your risks, just share in the chat, what's your number one risk that you see? And once you've done that, I'm going to share some of the risks that I think you need to be like most aware of. What's your number one risk that you see? Cool. Influx of patients, Naveen. Expenses, losing patients to other practices. Yeah. Managing expectations. For me, there are probably three big risks, okay? And I'll speak to those now. Probably four. First of all, in a private setting or a mixed billing setting, and bulk billing, so this is both settings, there's been a reduction in rebates for 721, 723, 732. Now 2712 is going, 2713 is going. So there is a significant reduction in rebates that is going to affect both types of practice billing model because of co-billing. So that's number one. Number two, there's going to be a downward pressure on appointments in a private or mixed billing setting. So downward pressure on appointments, which means empty appointment slots, possible and likely, especially because many corporates are flooding their practices with bodies. Sorry, second of all, so that's in a private or mixed billing setting. In the bulk billing side, there is a potential pressure of increase on appointment demand. Okay. All right. So maybe you can identify with this. There'll be a day where you've been in, you've worked like a donkey, you've worked hard, and then you look at your billings and you're like, huh? That does not feel right. Surely I worked harder than that. There'll be other days you go in, it feels light, you've done meaningful work, you look at your billings, it doesn't feel heavy, but your billings look high. So if there's an upward pressure on appointment demand in a bulk billing setting, there's going to be less of those days because there's going to be an influx of demand, which means there's less deliberate work. And in both of those settings, those two previous pressures are going to lead to your third big risk, which is GP retention. And that's going to manifest in a couple of different ways. Okay. And so in a private or mixed billing setting, you're going to find that especially the passive GP, the GP who expects everything just to be served to them. Does anyone know someone that might be a little bit like that? That GP is going to notice less appointments, less rebates, less billing. So guess what the next conversation is? Can I pay less service fee? And some of those passive people may not have thought through things. And so they may get things like this. Let me share my screen again. Coming through. Some of you may have received, which is like Timu Primary Care, who are promising all sorts of riches. And the passive people may well not examine their thinking properly and just in a negative state, a bit of panic, make poor quality decisions when they're promised things. Who has seen or heard of someone who has received these things? Maybe you've received it yourself. Maybe you thought, oh, that sounds all right, I might give them a call. This is a reality. Yeah. And this is all sales bullshit because once they get in, they'll just smash them hard, just like the old primary did. This is just Timu primary, the new primary. All right. And so there is a significant risk around retention. And the way you mitigate these two things is going to be what we talk about during the course of today. We'll be coming to that. All right. Are we clear on those risks? The fourth risk is actually one that is an irritation because it's another form of us doing government work, which is MyMedicare registration. And so the risk is patients who are not homed in one place, you're going to see more nefarious behavior where they magically get registered at other practices. Who's seen or heard that happening already? People randomly getting registered at places. And so we've got a couple of Project X people here on next week. We'll be giving you the role scorecard for that role to solve the MyMedicare issue. But it's absolutely happening right now. Okay. All right. So that was our first key principle, is mitigating risk. Okay. We'll keep moving. Okay. So back to the workbook. In this workbook, we've got some general information with the links, how the bulk billing incentives work, etc. We're not going over that today. We're going to do the real stuff. Okay. But it is important because when I've looked at information out there, no one is talking about this quadruple whammy, triple or quadruple. All right. This is the stuff you need to be thinking about, because people are thinking, should I sign up for the bulk billing PIP or not? Doesn't matter what you do, but you need to be thinking about these risks and mitigate those, because they are the sort of big threats to your practice. Because if you see a downward pressure on appointments, you've already got a downward pressure on rebates, then service fee questions come about, then that is a potentially catastrophic revenue event. And so we need to be very, very careful about how we mitigate that. So I'm glad you're here, because that's what you're going to walk away with a plan to do. All right. We haven't even talked about some of the other stuff going on around non-GPs being given prescribing rights and effectively cheap versions of GPs being trotted out to the public who aren't actually qualified to do general practice work. Who's seen that happening? Pharmacists prescribing, now RNs with questionable training that's going to be in place, and guardrails, straight out of the NHS playbook. So we need to the way we're going to mitigate that is through being intentional about seeing the patients that we see and having less patients, and working in a proactive planned care way, which is tied to the best way that general practice works. All right, so that's the way we're going to mitigate it. All right. So Todd and I did a podcast a little while ago. You may have seen it, you may have not. But the question was, how would you design something that could allow a GP 10 weeks off, give them 4 days a week, so they're working 168 days a year, have them see a max of 30 patients a day, and then we worked out what would that involve in terms of patients a year, etc. All right, so like for a full-time GP. And so as I walk through the next part, we're skipping to design your day as the principle. I need your permission, and I need you to put aside all of your preconceptions, all of what you know to be true, and just think of approaching the way you work in a completely different way. That's a big ask. It's a big ask. But if you'll indulge me, then we might see a different way of working. Could we do that? Put the skeptic hat on the side, the one that you wear proudly when the drug rep's trying to, sell you something. Just put that one off, and let's just examine a different approach. I'm going to give you one example, not to say that is how it should be, but as an illustration of that is how you should approach the problem. So not how it should be, but how we should approach the problem. Okay, let's go. Okay. So this is an example of a different way of working where your appointment book, the appointment book, is filled with planned care first. Right, so you'll have heard rocks, pebbles, sand, water. You'll have heard that analogy. How you fit the most volume into a jar is by putting the big rocks in first, then put pebbles, then put sand, and then fill it with water. Right? And so in this context, the big rocks are the bigger chronic diseasey type things first, and the other stuff fits around it. Okay, so I'm just going to give you a worked example. All right, so in this setting, this is someone who is doing 2 707s a day. It might be another type of health assessment, but 2 health assessments a day. Okay, they're doing, for those health assessments, one in two of those probably. So 1 a day may have a DMMR. 10 a day will have a new GP CCMP or a review. 4 a day will have a level C consult, and 13 a day would have a level B. So this is this person's non-procedural. They're just simple consulting. And so in this situation, okay, on the right you've got the item numbers, the item counts for each item number. But based on that, their billing without any bulk billing incentive would be 551,653. And in the MM1 area, they're in the new world, their bulk billing incentive, okay, would be 78,456. So different item numbers will attract different bulk billing incentives, not the bulk billing PIP, it's the bulk billing incentive. Okay. All right. And so what you would see is that in a year, based on this, remember, 10 weeks off, including public holidays, 4-day weeks, and 3-day weekend, maximum 30 patients a day. That is a long day. It's a 9-hour day. What that essentially boils down to, we won't spend ages on the numbers because, you're smart enough to work that out. Including the bulk billing PIP, this should say D, the GP would go home with 444,000 with an hourly billing rate of 462.35. Okay, what it means is someone working like this, okay, would need to have 560-ish patients with a chronic condition if they did 3 of those services a year, so every 4 months, not every 3 months. Okay, and what we know is from the AIHW, okay, and the links there, that across ages, an estimated 61% of people have chronic conditions. And some of you who've been collecting patients for a bit longer than others, you may have 80% of your patients have a chronic condition. And newer GPs may have less. But the principle here is designing your day with these things first and fitting these things around it. Now, it comes with risks, and we'll talk about trade-offs down the track. That's the other principle we haven't covered yet. If you're in a private or mixed billing practice, this way of working can still happen. In this situation, it would be a 35-65% split. So, but this is an example, and it means for the practice as a service fee, including in this example this is a bulk billed example, but it can equally work in a private setting or a mixed billing setting. Okay, so in this example, without the bulk billing PIP, 220-ish service fee, and including the bulk billing PIP, 255,016. Now, for this to work, for this to be solid, it means you have to become selective about who you would take. It's not all comers. It's not every patient who walks in a bulk billing environment, and similarly in a private or mixed billing environment. And so you'd need to do some education about them being tied to your practice, probably using MyMedicare as a mechanism, and you'd have to have some mitigation against the random MyMedicare registration when they walk in somewhere else, often without even knowing and not even signing something. Who's had patients out of interest that have been gone somewhere, haven't signed anything, but have ended up MyMedicare registered somewhere else? Who's seen that happen? Yeah, absolutely. Breaking the law. There's unscrupulous people doing that. Okay, so that is this example. There's another worked example in an MM4 situation. Okay, but the part that you need to reconcile with first is to understand what the potential of chronic disease burden is in the community for you. And so there's general information across the whole population. but you'd want to interrogate your database to find out what your practice-specific situation is. Who suspects they have 50 or 60% of patients with some sort of chronic condition? And so, again, this is approaching it a different way. This is planned care led, not patient demand led. But there are some trade-offs that we'll talk about in a moment. And so where it starts, and this is something you can do yourself after, is to just think about what is our current day? What does it look like? And if you're a non-GP owner, you might do it with whoever is amenable in your practice, maybe the principal GP. You might want to experiment with yourself first. You can be the guinea pig. But you want to see what the current is and then design how you would like it to be. But it does require a different approach to how we may have operated before, and it may be confronting and difficult to work through, and it will require some leadership to go through change management. And so what we've got in the workbook for you is your own worked example. And you can use it whether you're intending to stay private or change to bulk billing, whatever it is for you. But my encouragement to you is to reverse engineer it in a different manner. Okay, now we're going to keep moving. So the third principle, so we've talked about so far mitigating risk, and we've talked about designing your day. The third principle is the trade-offs, and you need to decide on your trade-offs. And so this is where we're going to spend a little bit of time. Okay, all right. And so there's about 25% of people here are probably going to be bulk billing, 10-15% not sure, and 60% have decided to stay mixed or private. That's my read of the chat so far. Okay. And so as I talk through this, I'm going to start with the bulk billing consideration, and then I'm going to also give you some reference and thinking in case you are mixed or private, so that we've covered both sides. All right. So the first is around if you privately bill in a bulk bill setting, okay? In a bulk bill setting, if you privately bill even one unreferred item, then your whole bulk billing PIP for the quarter, for the whole practice, is at risk. So just one mistake, the whole thing is at risk. Okay? And so the mitigation for that is training and systems. So that's a bulk billing environment. In a private billing environment or a mixed billing environment, your big risk here, your trade-off that you're going to need to decide is your pricing. Make sure you have optimized pricing. And second of all, your biggest risk that follows that and the biggest potential trade-off is the risk of becoming a ghost bulk billing practice. So what I mean by that is you might be someone like Kath that we worked with, who had owned a practice for 10 years, had a beautiful sign, private billing. It had all the fees on it. She's a non-GP, bought the practice when it was just one GP there, had grown it to 10, but was still not getting a financial return. And when she looked under the hood, she found that only 20% of their level Bs were being privately billed. And this is a big risk with perceived patient pressure to bulk bill that could slip in. Who thinks some of their doctors might be vulnerable to that if patients start asking or putting pressure in the consult room? And so what Kath did was, we call it the KT system now, but what Kath did is she discovered that and realized, oh, that's why I'm not getting a return. And so she had three things that she implemented. Number one, she did something called the first class formula to unpack the situation with the doctors. She then set up something called a a step-up program for the altruistically bulk billed, the unintended bulk billers, to graduate them to a private pathway. And number three, she took it out of the doctor's hands because they felt uncomfortable with the conversations. And what she found is over 8 months, initially within 5 months, it went to about 80% of level Bs were privately billed. And by 8 months, she was at 93% of level Bs privately billed from a starting point of 20%. And so we call it the KT system now in Project X that we teach. And I asked her, what did you learn? Did you lose patients? She said, we didn't lose enough patients. But she said, you just got to have the tough conversations. You've got to really understand the barriers to the problem that the people involved are facing. And then you've just got to hold the line, repeat, and keep measuring your progress. Those were her big learnings. And so if you're bulk billing, you've got to really watch your training and systems around even one getting privately billed. And if you're privately billing or mixed billing, you've got to make sure your billing rules don't slip, because you could end up being a bulk billing practice without realizing.